Okay, welcome everybody. Thank you everybody for joining us. This is session 2B, Involuntary Treatment Legislation in Ontario and Substance Use Disorders, Fit for Purpose. My name is Pia Heikkinen and I'm the moderator for this session. Before I introduce our speakers and before we start, just a couple of reminders. This session is being recorded. If you have any questions during the session, please enter it into the Q&A box. I'll deliver it to the speakers once the presentation is over. You can add comments in the chat, but please make sure that you add any questions you want the speaker to answer in the Q&A box rather than the chat. So that's very important. Once the presentation is over, you can also raise your hand if you'd like to ask the speakers a question directly. And I think that's all the business that I need to help. But I would like to start by introducing the speakers for this session. So we have Angie Hamilton. She's a retired lawyer, the executive director and co-founder of Families for Addiction Recovery, and the parent of a child who struggles with addiction. Angie is a member of the Policy Committee of the Canadian Society of Addiction Medicine and a board member of the Ontario Family Caregivers Advisory Network. Angie is or has been a member of various advisory panels for Toronto Public Health, the Office of the Chief Medical Officer of Health of Ontario, and the Canadian Centre for Substance Use and Addiction. She was a member of the National Board of MAD Canada and the chair of their Public Policy Committee. Thank you, Angie, for being here. And Valerie Primeau is a bilingual psychiatrist in North Bay, Ontario. Passionate about quality improvement, leadership, and advocacy. She holds a position of North Bay Regional Health Center Psychiatry Medical Director, as well as Head of Service of Community Mental Health and Addictions. She is the physician lead for the RAM Clinic and the Early Intervention for Psychosis program. She was a recipient of the NOMA Clinical Innovation Opportunities Funding for a research project on substance use stigma among first responders and ED staff. She sits on the executive committee of the Ontario Psychiatric Association, the policy committee of the Canadian Society of Addiction Medicine, and is actively involved in the section of addiction psychiatry in the Canadian Psychiatric Association. She recently became a founding board member and treasurer of the Canadian Academy for Addiction Psychiatry. So welcome, Angie and Valerie. Great to have you here. So I will hand it over to you folks to start the session.
Thank you so much, Pia. Angie's actually going to talk first, but before we get going, we were hoping to survey the group here. Thank you all for joining us this morning. So we just have 2 polls to start the conversation today, and I encourage you to keep the link open because we will be using the same poll link when I have my section afterwards. So the first question is just to get a sense of your understanding of whether or not a patient suffering from a psychotic or mood illness could benefit from an involuntary intervention. Right now, we have 5 people that have answered. I'd like to encourage people just to try it out a little bit. It's anonymous, so you can write an alias. You don't have to write your name to any of the polls. Just hoping to get a bit more answers before we move to the second one. I'm going to give people a minute. Oops, there's something in the chat. Okay. If you tell me what your issue is. Oh yeah, I see why. Okay, 1 second. It's because I put my full name. That's on me. There you go. Sorry about that.
Christy is asking, I'm not able to see the screen, the poll. And I think, Valerie, if they scan the barcode or go get the link from the chat, then they'll be able to see them better. Is that correct?
That's correct. Yeah. So unfortunately, poll area. So we were hoping to have the polls built in Zoom, but that was not possible. Unfortunately, poll everywhere reformats for high resolution, and there's nothing I can do about it. I apologize about that. But if you do use the link or the QR code, you will see it on your device or your website, and then you'll see it in the right format, like with the right font. I'm sorry that it's small. It looks like it's working now because we're getting lots more answers, which is great. Sorry for the confusion about the username. Great. So in the interest of time, I'll move to the second one. So we've asked you about a patient suffering primarily from a psychotic or mood illness. Okay. I'm going to move on to the next poll, which is about a patient with a substance use disorder. Would you answer differently? And then go ahead and place your answer in there. I just reposted the link in case that's still not working. Oh, it should just automatically load the new question.
You can perhaps just copy and paste it into your web browser. Try that. If
I
that
made the
hasn't
QR
worked.
code a bit bigger, if that helps.
And if you could just go in the chat and grab the copy the link. Oh, somebody put it in there again. Thank you, Chris. You should be able to click on that now. It's in the chat. Thanks again, Chris.
Yeah, thank you. And apologies, this was a last minute change from using Zoom. So I appreciate everybody dealing with the technology piece. Okay. As you can see, it's a little bit more spread out when we discuss patients with SUD, but many of you said yes. So, and what we're hoping today is to discuss essentially the legislation around that and look at a clinical lens about this topic. So I'm going to stop sharing in order for Angie to get started. So thank you for answering the poll, everybody. Keep your link open because I have a few more polls later on. I'll have the code still, but just in case. Go ahead, Angie. And you are muted, Angie, just so you know.
Sorry, had to stop sharing to unmute. Okay. Thank you very much for joining us this morning for our session on involuntary treatment. This is my disclosure. A couple grants, CIHR and SHRC, a little bit of honoraria, and I'm with Families for Addiction Recovery and of CAN as well. So today our objectives are to, at a high level, obviously, we haven't got a lot of time, understand the current involuntary treatment legislation in Ontario in the context of substance use disorders, discuss the shortcomings of the legislation as drafted or as applied from the perspectives of families, psychiatrists, physicians, and briefly discuss recent approaches in other Canadian jurisdictions. And I'd like to start with a bit of context. I think everybody knows there's increased interest right now because of encampments, et cetera. But I did want to point out that this has been a really important issue for families going back to before 2010. In the year 2009, the government of Ontario set up a committee to travel the province and talk to all the stakeholders involved with addiction and mental illness to look for things that could be done to improve our system. And the report came out in 2010, and one of the recommendations was, in fact, with respect to involuntary treatment. And the committee held that the right to autonomy must be balanced with the right to be well. And I can't say it any better than that. So oftentimes people say this is a violation of rights. It can be if it's done wrong, but done right, it is balancing the person's autonomy with their right to be well, because an individual's rights can conflict. And as we all know, sometimes with severe addiction, a person's autonomy can be severely compromised. They pointed out that our present laws, that's back in 2010, tie the hands of professionals and families, and that's contributed actually to the criminalization of mental illness, where people need to be arrested in order to receive the care they need. They did point out that there's a lack of resources, but also that's not the problem here. The problem is that they won't, sometimes the nature of their illness is that they will not reach out for help. And then they also mentioned the importance of early intervention with many psychiatric conditions. So notwithstanding that, in 2011, the government said, hey, we're going to set up a task force to look at that. And they've done absolutely nothing ever since. And I think that speaks to the power of family caregivers, that they haven't had to address it. But as we all know, what's happened now is there's a lot of encampments. People are complaining that they don't feel safe. And so there is all this interest all of a sudden in involuntary treatment. We know that there are two Angus Reid polls in 2019 and 2021, both showing an overwhelming support for involuntary treatment of individuals with opioid use disorder, and that's adults, not just minors. Notwithstanding that, the government hasn't moved. So other players are getting involved. For example, the Ontario Association of Chiefs of Police last year, they called on the government to prohibit basically hospitals, psychiatric facilities, other health care facilities from refusing people on mental health grounds if they're intoxicated, and they want them to establish policies and procedures to ensure that they're basically treated with the same consideration as other people, notwithstanding that they're arriving intoxicated. And they wanted the government to ensure that there's adequate funding for security in the hospital, withdrawal management protocols, stabilization, and treatment for the person who is intoxicated and may have concurring conditions. So quite an indictment of the current system. Furthermore, also last year, the Ontario big city mayors, they said, look, we're not professionals, we're not the experts here, but looking at what's happening on the streets, we think the government needs to look at updating the Mental Health Act and the Healthcare Consent Act dealing with capacity, because of the realities of the crisis on the ground, and to determine whether we need to expand it or something, involve all the stakeholders, including the municipalities, to look at this. And Doug Ford said no. So this to me is the most important slide. Health laws are there for a reason. And there are two health laws that are designed to protect people with mental health conditions, including addiction. And they're designed to solve problems for difficult situations. So the first one is, what do we do if someone is at serious risk of harm to themselves or others due to a mental disorder and they're not seeking treatment? That, of course, is the Mental Health Act. And the second one is, what do we do if somebody's lacking capacity to make treatment decisions? And that's the Healthcare Consent Act. And these laws, again, they're designed to ensure safety of everyone, the person with the condition, protecting them from themselves, protecting them from others, and also protecting, if necessary, others from them. So does our Mental Health Act currently apply to substance use disorder? And the answer is it always has. Unfortunately, the realization of that has been quite late in the game. So this reflects a paper done, which I'm very grateful for, in 2020 by a number of physicians and lawyers, mostly with CAMH, looking at this issue. And it was called Rethinking Involuntary Admission for Individuals with Severe Substance Use Disorders Presenting in the ER. And they looked at the two criteria, whether it was a mental disorder was the first criteria, and the answer is clearly yes, both because it's in the DSM, but secondly, because there's any number of decisions of the Consent and Capacity Board showing that it is a mental disorder. And then the second criteria is, can this result in serious harm, either serious bodily harm or serious physical impairment? And again, the answer was obviously yes, because people are dying. So they then turned to the logical question, which was, so why is this so underutilized? And they speculated that it is therapeutic nihilism or worse, stigma. And stigma, of course, just another way of saying discrimination. And I would say that that's the experience of our families, is that there is a lot of discrimination and these protections aren't being applied to our people. And I'm also grateful for this second bit of research from CAMH, and this came out last June. And they did a really interesting research into the reported decisions of the Ontario Consent and Capacity Board. Now, only about 10% of the decisions are actually reported. It began in 2003, and they finished their research, I think, in June of 2003. So this covered pretty much a 21-year period. And they looked at they search for substance use terms, like alcohol use disorder, opioid use disorder, and then the medications used to treat. And they found that there were only 71 of the reported decisions that talked about this. There were only 6 of those where they looked at capacity to consent to substance use disorder treatment. And they found that there was only one case that upheld a finding of incapacity with respect to methadone treatment, because the individual didn't think that they had a substance use disorder and therefore they couldn't appreciate that they needed treatment with methadone. And their conclusion, of course, was we really need to assess people to see if they have capacity when they consent and refuse to make decisions with respect to OAT and other treatment for substance use disorder. And again, I'm grateful for this, because it is the feeling of families, anecdotal, that that our loved ones aren't being assessed to see if they have capacity. It's really important, because if they don't have capacity in Ontario, a lot of them, then the decision goes to the substitute decision maker, often with respect to a child, that is the parents. And so if you're not looking at that, you could be denying us of our right to ensure our children get the treatment that they need. So just to give you a bit of a flavor for what are the decisions under the Consent and Capacity Board, the 2019 one first listed there, that is the one that was referred to in that research letter. AJ is a case of a 43-year-old mother. She she was into her work. She had a PhD. She lived with her parents, her partner, and her 2 children. But there obviously was an issue of safety for the family, because the police had a no contact order between her and her children, and the family was in the process of getting a restraining order. So she was actually facing homelessness, and I'm actually happy to see them considering that in their decision. They said she had a substance use disorder. She had a history of overdoses. Just like, honestly, I don't know how anybody could read this and think we don't need involuntary treatment sometimes. It's just like watching somebody reading about someone torturing themselves. At the end of the day, what did it for the doctor and said that we got to do something is that she consumed antifreeze, and given her background and what her PhD was in, she would know that that was potentially life-threatening. And they found that she was at serious risk of bodily harm from a mental disorder or substance use disorder unless she remained in hospital. The other case I wanted to discuss is RE-CC, and that was a 34-year-old with schizophrenia, traumatic brain injury, IV fentanyl use, living in a shelter. He had recently assaulted mall security, had overdoses, etc. He had a community treatment order that required antipsychotic and Sublocade. He wanted to switch to oral medications. And basically history showed that he, might think that he's going to take his medications, but he's not. So they did not allow him to switch, and they made the antipsychotic medications and Sublocade medications part of his CTO. So if we have 2 laws designed to protect people with substance use disorder, in particular right now, the involuntary treatment, why aren't we applying them? And there's a number of barriers, but for me, a big part of it is there is a lot of concern, rightfully so, over how this could be done effectively and to ensure that the harms of involuntary admission and treatment are minimized, because it has historically been done wrong in many places. So this is just like a list of all of people's concerns. I don't have time to address all of them. I do want to address the first two, though, which is it ineffective and does it violate ethics? So I was a co-author in the CSAM systematic review published in 2023, PHI. We looked at 42 studies and concluded there's a lack of high quality evidence to support or refute involuntary treatment for addiction in comparison to voluntary treatment. Now, I actually really wanted this research to be done because families' experience is that we were continually told it doesn't work. We all know it doesn't work. So we have a lot of empathy for you, but you forget it. It doesn't work. So something that says we actually don't know it doesn't work is really important. And for example, you don't research something if you know it doesn't work. But we haven't seen any pilot projects in Canada to see, if this could work even with respect to youth. But more importantly, it doesn't work compared to what? And this is where I think families get really concerned, because the alternative to involuntary treatment is not voluntary treatment. I mean, if they would go, that would be great. If they were willing to get help, that would be wonderful. We're talking about people who will not do that. So the alternative is untreated addiction, and we know far too well. A lot of us have a front row seat to what that looks like: sexual exploitation, incarceration, homelessness, serious health issues, brain injuries, death. That is traumatic. And if they die, the trauma just continues for the families. So this is my message. We absolutely can build a system where any harms and trauma of involuntary care are less than the harms and trauma of untreated addiction. It has to be decided on a case by case basis. It's like, so what I'm saying is if we're looking at someone, whether they should be involuntarily detained and treated, we need to make sure that for that individual, the benefits will outweigh the harms. This is not a one size fits all solution by any means, and probably is not needed in the vast majority of cases, but it does need to be an option for some people some of the time. And I just do want to speak for a moment to what the evidence was that we saw. And there were 10 negative studies, and negative simply means that the results and outcomes were not as good for the involuntarily admitted patients compared to the voluntarily admitted patients. But I think what a lot of people don't realize is 50% of the negative studies, people did not receive evidence-based treatment who were in the involuntarily admitted group. And four of those studies, they compared people voluntarily receiving methadone maintenance treatment with people who were involuntarily detained and quote unquote treated who did not receive OAT. And to me, when that's the case, you can't conclude, as some do, oh, see, involuntary treatment doesn't work. I think the best conclusion of that is that for involuntary treatment to work, it is essential that people receive evidence-based treatment, just like it's essential for people who are voluntarily being treated. Three of the studies actually, of the negative studies, only involved voluntary patients. There was information to take from that. But my point is there were only two of these studies, both Norwegian, that actually compared voluntary to involuntary patients, where both received evidence-based treatment. And I think they were overwhelmingly positive. So Passerina was 2016. At 6-month follow-up, there was a significant reduction in drug use in both groups. And with respect to abstinence, there was 50% for the voluntary group and 24% for the involuntary group. But, and this has to be addressed, there was much higher ODs rates for the involuntary admissions, 22% versus 1%. And I have not been able to confirm if the treatment that they got was OAT or not. If anybody knows, please let me know, because I wrote the author, but I haven't heard back yet. So that is absolutely a concern. But they concluded that we should keep going because the alternative is no treatment at all and continued life-threatening drug use. In OPSL 2019, which is actually 3 of the 5 authors in Passerino, same people. And this is really interesting to me, and I think very important. It showed, I think shockingly and surprisingly, that the majority of the involuntarily admitted patients were at the highest stage of change for readiness to seek help at admission. And by the time they were discharged, it neared the motivation level of the voluntary patients. And not only that, but the only predictor of continued drug use at follow-up was severity of the substance use disorder at admission, which in both of these studies was the severity of SUD was higher for the involuntary group than the voluntary group, i.e. they're sicker. And really importantly, readiness to change was not a factor to predict continued drug use. And there's all kinds of, I don't have time, but I encourage you, if you're interested, to read those. They're really interesting studies. I think we also have to ask if there's a better alternative to involuntary treatment. And when I ask people who are opposed to any kind of involuntary treatment, what's their better solution? Again, in situations where the Mental Health Act applies, I haven't heard one yet, except possibly harm reduction. And I do want to say that absolutely support consumption and treatment services and harm reduction. That said, I do want to point out that I don't believe currently the majority of people with severe addiction, just include in that alcohol and all substances, use these services. I think a majority of young people are smoking their drugs, and the consumption and treatment services aren't set up for that. And furthermore, a lot of our family members are telling us they wouldn't use one anyway. They want to use alone at home, and I can tell you that they do not call Norse. And sometimes the same people who are unwilling and incapable of accessing treatment are unable and unwilling to practice harm reduction. And what are we going to do then? So this isn't, criticizing harm reduction. It is saying harm reduction is also not a one-size-fits-all solution. And we have to consider others who aren't using these services and won't. Ethically, I'm really disappointed that we're in 2025 and people only ever seem to be questioning the ethics of intervening. If you look at the situations that we're talking about, and if you look at some of those cases currently at the consent tribunal, consent and capacity tribunal, it's horrific. And it's time that we started to ask about the ethics of not intervening, because really what you're saying is we're just gonna, we're gonna wait for them to be able to pull themselves up by their own bootstraps, and many will not be able to do that. And we're no better with respect to minors. We have no greater protection of minors. In fact, they're waiting longer for services. And when they wait, if they're waiting for mental health services, a lot of them develop a substance use disorder because they're self-medicating. And I would say, again, with respect to minors, the lack of treatment on demand for mental health and addiction, the Auditor General just came out with a report, but the lack of treatment on demand, together with a lack of ability to intervene to protect them if they don't want help, is, to me, it reflects a state of negligence in our healthcare system, a state of neglect. And neglect, when we're talking about minors, is a form of child abuse. So to me, it's like systemic child abuse. Okay, just wrap up quickly what's happening in BC and Alberta. So in BC, their provisions are actually quite similar. There are striking differences in how it applies. But it can apply if there's a mental disorder, and the criteria in 2 and 3 here, which is a lot of harm to self, harm to others, they're considered mental impairment. There must be both a mental disorder and mental impairment. It is my understanding that unlike in Ontario, mental disorder, by all the board decisions looking at consent and capacity in BC, say that that substance use disorder is not a mental disorder. So in order to try to rectify that and get the act to apply, the Ministry of Health has come out with new guidance, and it clarifies that no type of mental disorder is excluded, i.e. it can be for substance use disorder. And but there has to be mental impairment. And then they talk about 3 types of scenarios. One is where there's concurrent disorders. Another one is if there's a known SUD or they show up intoxicated and they're showing psychiatric symptoms showing that there may be other mental health conditions. You can keep them to determine what the situation is. And then if the you determine what the other psychiatric issues are and the mental impairment persists, you can keep them. Lastly, Alberta, I think everybody knows they're going to introduce a Compassionate Intervention Act in the spring or fall. They have announced that there are going to be 2 facilities of up to 150 residents. And they have provided insight of what it's going to look like in their white paper, which was released in March. And it shows that they're framing it as a healthcare intervention with procedural fairness, which means there'll be a right to appeal. It's going to be person-centered, longer bed-based treatment. I think that is the one thing that families would say is the real problem with our current act is it's just a revolving door. They're very short-term holds and it's not long enough. There's going to be long-acting medications, so none of this, no OAT. It absolutely is going to apply to alcohol and legal drugs as well. Social reintegration and transition and aftercare. So that sounds pretty good to me, devil's in the details. Lastly, what are the insights from the literature? Very clear that we need to minimize law enforcement involvement on transport, the procedural fairness, the explaining to people what's going on, involving them in the process to the extent possible, respecting their autonomy. And to me, the most important thing, and this is again from the Norwegian studies, they really thought why their results were so good is because they integrated the voluntary and involuntary population. So one, that ensured that they got the same evidence-based treatment. They got the same evidence-based treatment. And that's, the rest of this is kind of the same. So thank you.
Thank you, Angie. I will get mine going. Sorry, I'm just making sure that I got the right. Okay. Tough act to follow. Angie's excellent presenter. I'm hoping to walk you through a very brief analysis from a clinical lens, and just explaining where maybe we can utilize the legislation to assist in treatment in the community, and then what are some of the limitations and pitfalls currently. In terms of my involvement, rather than just kind of bore you with details, and you already heard my bio, I just wanted to let you know that my primary roles are around like quality improvement and helping vulnerable populations. So I am the REM physician lead. I also help early intervention for psychosis patients as well. And so my lens is looking at early intervention and how we can support individuals who are reaching out for help and individuals who may not have always the insight to know what's best for them from a treatment standpoint. I do have to disclose that I have received financial support to attend the CAP annual conference, and I am a board member, although I do not get an honoraria for that. So I wanted to run through a case. I find that's always the easiest way to understand the potential kind of indications and pitfall of what we have currently. So this is a 37-year-old female who has been admitted for 4 weeks in hospital, 8 different admissions over the course of 2 years for psychosis, diagnosed with schizophrenia by different psychiatrists over the past 2 years. And it's complicated by significant methamphetamine usage. I'm seeing a lot of chat. I'm just going to make sure that it's not that you're having issue. Oh, yeah. Okay. Is there an issue with my slides, or can people confirm that you can see my slide? Angie, are you able to see my slides?
I am.
Okay. Just making sure that it's not on my end. Okay. So the course of the illness, this person is complicated by significant met usage, which is very common in Northern Ontario. So I practice in North Bay. And then in the hospital, this person gets better with treatment, which is a combination of medication, supportive therapy, and abstinence from the methamphetamine. Sadly, though, closer to discharge, they have a pattern of disengagement from services when they leave in the community. They don't adhere to their medication regularly, and they tend to go back to using stimulants, which tells us in psychiatric term that there's likely poor insight into the mental illness. When you talk to her, then she tells you she wants to go home, she feels better, which the staff does report. Indeed, this patient is much better. She feels she's okay taking the medication, but when you press her further, she's like, I don't know that anything bad's going to happen if I stop it, if I don't take it every day, which has been the pattern in the past. And she's also ambivalent about whether or not the methamphetamine will contribute to her psychosis and schizophrenia diagnosis. And at this point, the answer you get is, I'll be fine even if I use a little bit. I'll be fine if I don't always use my medication. So based on that information, would you believe this patient would benefit from a mandated treatment intervention? And by that, I could mean, like, for example, a community treatment order to ensure compliance to her treatment for schizophrenia. All right, so the majority of the people answering right now are saying, seems like that would make sense, right? That this patient might meet criteria for a community treatment order based on that pattern of non-adherence and that poor insight, right? So, and we do know that patients with schizophrenia tend to have poor insight chronically, so that would fit with that. So I'm going to take that, and what I'm going to do now is just substitute the diagnosis to drug-induced psychotic disorder. I'm not going to change anything else in the vignette. This is actually exactly a case that I've had in my practice, and I'm going to ask you, does that change your answer? And while you're answering, I will tell you, I had a patient that was a severe methamphetamine user. It's very common, as I said, in Northern Ontario. And they kept being in and out with psychiatric admission for what we believe was drug-induced psychosis. As you know, the line sometimes is a bit difficult between drug-induced psychosis and schizophrenia, but all the episodes had started with the methamphetamine usage. I did end up placing that patient on a community treatment order with long-acting injectable. And upon discharge from our program, so she was an early intervention patient. So I changed the age and the details a little bit. Upon discharge from our program, was on no medication, abstinent from methamphetamine for at least a year, and functioning really well. So I would consider that to be successful in that case. And then I'm going to take this and I'm going to take you guys a little bit further, and I'm going to change a few more details, and I'm going to talk to you about a patient that primarily suffers from severe opioid use disorder, where the treatment is slightly different, right? It's opioid agonist therapy, such as Sublocade or Suboxone, where the treatment in the community would be continuing that OAT, and where the risks are slightly different, but the insight is the same. And the risk, again, are medical complication or dying. And if you look at that, right, the details aren't changed that much. But how do you feel about that one? The insight is the same, but the details are slightly different. So what we're seeing here is, like, there's more people that are like not sure, right? It's like, does it apply here? Does it not? Does it make sense? Does it not make sense, right? But there's a good majority also that says, yeah, that probably wouldn't change because the insight's the same. And I think that's great to have that conversation, right? The goal of today is to have that conversation. So I'm going to move forward and talk to you exactly about, like, could the Ontario Mental Health Act today be applied in this last case, right? So the first thing that we have to discuss is the threshold for incapacity, right? Can individuals with substance use disorder meet the threshold? And Angie's already alluded to this, and I'm going to try not to repeat too much. I was curious if you guys know if there's any studies that have looked at that and whether or not you have a sense of what the percentage of patients likely would meet criteria for incapacity to consent to treatment in that population. You can just take a guess. Good news about these polls is that nobody knows what you're answering, so. The curve I'm seeing is beautiful, by the way, so. All right, so the majority of people are saying it's around like the 20 to 40% range, right? We're kind of seeing a bit of a bell curve, which is kind of cool. And interestingly, that's kind of like, there's not a lot of studies on this, but what I have seen is around that. And as you know, it's probably higher than that because like schizophrenia, we often underestimate the amount of patients that are incapable to consent to treatment. But there has been some studies that have looked at this, and it's around a third of patients. So I'll just remind you of the criteria for capacity to consent to treatment. You need to have basically two things: the understanding and the appreciation. And if you're lacking one of these, you're technically incapable to consent. And it can be for any decision, and it's dynamic and can change over time. There's many reasons why a patient could be incapable with respect to substance use disorders. If you think about it, psychosis was one that I pointed out in my example too, comorbidities, but also medical issues that come from the substance use disorder itself, such as brain injuries from overdoses, TBI, other neurocognitive issues. So there are multiple factors that could contribute to a patient not meeting that threshold for understanding or appreciation that is no different than any other patient suffering from a psychiatric illness. So we do need to assess it in that population as well. Oops. My computer's trying to launch thing behind my back. And then this is a study I thought was very interesting where they applied a scale or assessment that they normally would apply for research to determine if people meet threshold for capacity. And they noticed that about 30% of individuals lacked research-related decisional capacity. So it does indicate that patients with substance use disorders may have impaired capacity at certain points in time. So then the other question then is, are substance use disorders considered mental disorders? Again, Angie's gone a bit through that, so I'm not going to walk you through the legal part of it, but I did want to point out from a psychiatric or clinician standpoint that the Ontario Mental Health Act has never excluded substance use disorders, and they are in the ICD-10 or DSM-5 classification for psychiatric disorders. If you look at the definition of the Ontario Mental Health Act, it is any disease or disability of the mind. And I would say I'm a doer and not a thinker if people ask me, but I would say that the thinkers of our world who have done these fancy charts and have looked at the biology of addiction will tell you that it is definitely a disease of the mind, that there is no doubt about that. It does affect multiple areas of your brain. So why are we treating it differently? I think part of it is actually a bit of a historical division in psychiatry. It's similar to how delirium and neurocognitive disorders are usually not considered to be in the realm of the Mental Health Act. Part of it could come from case law as well, because historically individuals were typically held criminally responsible, even if they were psychotic due to the substance, as long as they made the choice, quote unquote, to use the substance. But that was based on the notion that they're all capable, right? When they made the choice to use the substance in the first place, which we just discussed is likely not the case. So that perception is also shifting. And I think there needs to be a clinician culture change as well, so that we stop having that division between psychiatry and substance use disorders. CAP, which I am a founding member of, one of our big message is that psychiatrists need to be part of the delivery of concurrent disorder services. We need to be part of treating patients with substance use disorders. They are part of psychiatry. So if you look at those two elements, yes, the act that we have currently can be applied to substance use disorders. So then the other question is, why are we not doing it regularly, right? You've seen Angie's article on the amount of review board decisions around this, right? And there's many reasons why we're not doing it, and I don't have time to go through all of them. Some of the ones I will mention in passing that Angie already covered is the perception that it doesn't work. And really, when you look at the evidence, right, we have some positive studies, we have a lot of poor quality negative, quote unquote, studies, and we need a lot better data, right? So that perception needs to shift a little bit. And then the other perception that Angie covered is that it's unethical to apply involuntary intervention. And my challenge as a clinician would be, if that's true, then why are we applying it for the mental disorders, right? And is that stigma then, right? Why is it okay to apply for a patient with schizophrenia, but not provide that potentially life-saving intervention to a patient with substance use disorder? And is it not unethical to not apply it if they're in imminent danger? No different than a patient with acute psychosis, right? So that is where I think we need to stop having that division as clinicians. There's another perception we will not address today is that we do not have enough beds, right? We don't have the right resources, or that we will take resource away from the voluntary patient, and we already don't have enough of those. And I think somebody in the Q&A already pointed out, what about all the social determinants of health that we're not looking at? And I totally agree with you. That needs to be looked at. So I am not saying that involuntary intervention would actually be the only thing that will fix this. It is just one tool in our toolbox that we could use more often, but it has to come with everything else: access to housing, access to evidence-based trauma-informed treatment, all of these other things that we are often lacking in our system. The wait lists have to change, right? There's so much that we are dealing with at the front line that is not addressed with this, and we recognize that. We all agree we need more resources for all patients with substance use disorder. That shouldn't be the reason why we don't try to offer the right service if we can make it happen, right? And it also shows a need, which then hopefully will drive more development of services. The other thing that I wanted to point out is that when my colleagues say, well, we might end up using more inpatient resources, well, these patients are already using a lot of resources in the healthcare system right now, right? They have the highest mortality morbidity usually when they have low capacity, and they're the ones that will be coming to hospital more often with very severe illnesses. So they are already part of the individuals that we treat. The perception that I will address briefly is that it causes a negative or detrimental experience. There is a concern, right, that involuntary intervention can be detrimental. When you look at qualitative studies looking at that, there's a lot of evidence that it actually is crucial to their recovery. And patients will mention that afterwards and be like, I am happy that I had this intervention because that got me back on track. So it is a fair fear, and we need to be careful about how we integrate it. There are studies that have looked at this, and there are patients that have said that they believe they needed the involuntary intervention in order to get better, that it was necessary. That's one, and that's another study. And the other piece that the patients mention is that the more positive experience was in the setting where they had a really good therapeutic alliance, a therapeutic bond with their team. So it's really important that it is done well, right? We do not want to create a sense of fear. That is not what we're talking about here. It needs to be patient-centered, trauma-informed, and empowering. The ones that I want to spend about, and I'm looking at the time and doing okay, a few last minutes on, is what I would call the paperwork aspect of our lives, which is some of the criteria limitation in Ontario, the high onus on the physician, the cumbersome CCB process if you are a clinician that have had to go to the CCB. And in general, I think there's a lack of awareness and education that we can apply the Ontario Mental Health Act. And I'm hoping that this presentation today has been helpful. So I just wanted to point out that there are a variation across provinces in terms of what a mental disorder and what the harm criteria is. And Ontario is relatively restrictive compared to some of the other provinces. So in Ontario, even though the Supreme Canada has it like wider, like in Ontario, typically our understanding is that it's limited to serious bodily harm and serious physical impairment. That's box A. I understand that it could include serious psychological bodily harm, although I've seen CCB not uphold that. So I think there is definitely still a disconnect there. And then we have the box B in Ontario, but it's a lot more complicated. There's a lot more conditions you have to meet, so it's harder to access. And it requires a history of prior response, and it has to be the same treatment and the same mental disorder. And then CTOs in Ontario also are restrictive in the sense that you have to have met certain conditions, and it has to be renewed every 6 months. So it again pushes us to have a patient fit in the box that they don't always fit in, but even though they might benefit from the treatment. So my takeaway is that it is really imperative that the Mental Health Act criteria is reviewed so we can expand which individuals are eligible for involuntary interventions and commute treatment orders, and that it is in line with what some of the other provinces are moving towards. And the Ontario Psychiatric Association is looking at that in general, like, and not just for substance use disorders. Another limitation is, again, every time we do a form in Ontario, there is an opportunity to challenge. Now, that is really important because a patient needs to have a right way to appeal the decision, and that can be done every 6 months. The issue in Ontario is that the burden of proof is only on the physician. And if you're a physician in the room today, you know how busy you are, right? So trying to find the time to be really proficient at going to these hearings is difficult. So it's not that we don't want to do it. It's just what we've seen is that physicians find it really cumbersome. They often can't pick the date and time of when these hearings happen. They have to do all the prep work, in between patients or after hours. And most of us are not necessarily like legal experts, right? So we will miss things that will be useful to us in the hearing just by default of the fact that we're not lawyers ourselves. There was one study actually that looked at this, and it was like 80% of the reversals were actually technicalities. So not actually the patient's condition, right? And that shouldn't happen, right? We should be able to say our expertise in terms of the patient's condition and not essentially be judged on the technicalities. So I do think that process needs to change as well. And there are some studies that have shown that when patients can test, sometimes it can lead to premature discharge, likely because the physician doesn't believe that they have the expertise or the information to go to the hearing and actually get it upheld. So I do think the takeaway is that we need to train physicians better and equip them and support them in applying the legislation appropriately, not over applying it, not under applying it. And we need to support them in this area. And I think the appeal process also needs to be reviewed so it's a bit more physician friendly, especially with the booking of the hearings and all that. Angie's already talked about this, but this just highlights that we are not going to the board very often for these patients. That was the study that she mentioned earlier, so I'll just skip it. The takeaway, though, is that we do need to use it more often when it is indicated and it makes sense. So I'm going to wrap up here. My hope is that the takeaway that you're going to have today is that we need to accept the notion that there is a role for involuntary intervention. Involuntary intervention doesn't mean just hospitalization. There is a realm of different intervention, like treatment orders, and that we should offer it to all psychiatric illnesses, right? It shouldn't be just restricted to certain areas of psychiatry. We have reforms happening across Canada. This is our chance for us to have a voice into what it looks like. If we have concerns, now is the time to tell our governments, the people that are leading this work, right? So that we actually make sure it is in the best interest of our patients. And in the meantime, I hope now that you'll be reminded that because substance use disorders have a biological basis, because we have these life-saving interventions that are medication-based, we can probably apply some of that legislation when the patient meets that threshold for incapacity. And hopefully you get more support in doing that in the system going forward. The goal is always to improve outcomes, save lives, and regain that autonomy, right? No different than a patient with schizophrenia or bipolar disorder. We have the involuntary intervention initially so that they get better, their insight improves, and then we remove it. I'll stop there because I think, yes, I might definitely am a bit over, a few minutes over, and then we'll hopefully answer some questions.
Thank you so much, Valerie and Angie, for a very comprehensive presentation, getting us all thinking. So we've got a few questions here. I'll start with the first one. Does the emphasis on involuntary treatment overlook the broader social determinants of health? For example, someone can be hospitalized involuntarily and stabilized, but where are they discharged to?
I'll start. First of all, I don't think there's an emphasis on involuntary treatment at all. I think what we just showed is that it's not being used when it could be. But absolutely, right now, this issue, frankly, in Ontario is completely moot because we don't have treatment on demand for people who want it. The point would be, we need to build both systems concurrently for voluntary and involuntary treatment. We need both at the same time. I get upset, a lot of family members get upset when we hear we have to build the voluntary system first, and then maybe we'll give a thought to these are the people who are most sick. These are the people who are at serious risk of harm to themselves or others. And if you're letting them walk down the street, I honestly think that's part of the reason for the backlash against harm reduction. If you've got people walking down the street who are at serious risk of harm to others and you're not doing anything about it, one, it increases the stigma. And two, people think, oh, it's those supervised consumption sites, when that's got absolutely nothing to do with it. So we need to build both systems urgently and concurrently. And absolutely, we have to help the families, because often they're going back to their families and the families have to change too. This isn't just about the individual. We have to figure out how to support them well. And same with society. We have to employ them. We have to reintegrate them. So this, as I said, today it's moot. There's no way in the world our government is doing this. But I like what Alberta has done to say that, they started talking about this years ago. What is the first thing they did? They ramped up their voluntary care, and they are now talking, and they're going to spend a lot of time structuring and discussing how this is going to be done in a way that improves outcomes. And they're absolutely talking about the importance of employing people, of social reintegration, and everything else. Because you're right, you cannot just pluck people out, do something, and stick them right back. That will not work, and that is a waste of money.
Thank you, Angie. Valerie, just in the sake of time, is there a question there in the Q&A that you'd like to address? We only have a few minutes left, and
I was actually answering some as Angie was talking, but very quickly, just some around like just the logistics of the CTO. I just wanted to point out that community treatment orders can be created or issued by any physician. So the Mental Health Act is very clear that it does not have to be psychiatry. So involuntary treatment is a bit different in terms of what is considered Schedule 1, and I'm happy to take that offline for you. But in terms of community treatment orders, it is physician based. Like, it's not required to have a psychiatrist involved, though it's a psychiatrist, so the most comfortable. I do have family doctors issuing them. And then the other question was more around like how to observe medication. And as you see, somebody just talked about the ACT team. So I wanted to mention, I actually have an ACT team right now. So I just took over an ACT team in January. And one of the things we do is daily meetings with the patient to ensure adherence to medication, which can be a combination of oral or injection medication. And so I have some patients on naltrexone where we just go and make sure that they take it every day and that they are on a treatment order for that, including their other medications too. And naltrexone is part of it. And then OAT has injections, right? No different than the antipsychotics. So we do have easier way to maintain adherence with OAT as well now in Canada. So I just wanted to quickly plug that in there. That answers a couple of the last ones.
Angie, is there anything that you'd like to address in the chat, just in the sake of time?
Yeah, I did actually just put it in there, but thank you for the question about what families can do. We provide free peer support to families, and it's based on something called the motivation to change approach. It's a combination of CRAFT, which is non-confrontational empathetic approach. It improves communication skills. It's also based on motivational interviewing and acceptance and commitment therapy. We can help them cope. We can help them accept what they can and can't change. We can help them improve their communications with their loved ones, and that will help motivate them to seek help.
I'll answer maybe one last question quickly about like, do patients transition from involuntary status to voluntary for treatment? And yes, usually what happens is the capacity is reassessed, right? And as the insight improves, then there's no need for the involuntary intervention, whatever that intervention is, right? So insight is dynamic and capacity is dynamic. So we only use the restrictive intervention when it's necessary, and that's no different than other psychiatric illnesses. When they regain insight, then we obviously will move to voluntary, right? And we do everything voluntary as much as possible. Again, no different than other psychiatric illness.
Thanks so much. And I put a link to the survey in the chat if folks wouldn't mind taking a moment just to give us some feedback on the presentation. It'd be greatly appreciated. And I just want to thank Angie and Valerie again. Thanks so much for coming and taking time to talk about this important topic. And thank you, everybody, for your questions. And moving forward, right now there'll be an hour break for lunch, and the afternoon workshops will reconvene at 1:30. So enjoy your break, everybody.
Thank you,
Thanks so much for
everybody.
coming.
Bye-bye.